Today's guest on the practice is a rare kind of leader, one who hasn't let success harden him, who has maintained empathy and an open heart. Dr. Omar Lateef is the president and CEO of Rush University System for Health and Rush University Medical Center. He's been recognized globally for leading with integrity, equity, and moral clarity, especially during the height of the COVID pandemic. He is somebody who will not walk away from a fight when necessary, but behind the titles is a story of perseverance and personal conviction. In this episode, we'll explore emotional, ethical, and personal costs of leadership and in medicine today. It's about what healthcare could become if we lead with clarity, compassion, and the courage to have conversations to fix what's broken, even when you're a part of the system that broke it. Omar, thank you for being here today. I am so pumped to have you on the practice. I'm pumped because I have a little bit of a man crush, right, on the human that you are. I've gotten to observe from afar about the changes that this guy has started to make in an institution. I've gotten to observe from proximate while working with and closely with you on a couple of different projects. And I've gotten to receive the benefit of transformative medical care with and for my patients. And so today, what I wanted to do is just have a conversation and get to know you better. Does that sound fair?
Sounds great. And Ari, I'll just start out with saying thanks for having me on your podcast. And you're quite a visionary. You're known all over the city for what you've done, and you're known increasingly all over the country. And it's a real privilege to be here and see your operation and how you're helping so many people. So
awesome, man.
I hope not to bore your audience.
That won't happen. So tell me about your origins, man. Where are you from? Like, what's the story? Tell me about mom and dad and siblings. Like, what are the seminal moments that formed who you are today?
Yeah, so that's like an action-packed question, which could overwhelm your audience with extreme boredom. But I'll start from, I was born in Youngstown, Ohio, sort of on the border of Pennsylvania and Ohio. A great town to grow up. Didn't have a curfew. Got to hang out all the time. Rode dirt bikes, skateboards, and just really had a great time growing up. Went to a great public high school. Played some sports here and there. Was on the speech team. Enjoyed that. And really got to experience kind of life in really middle class, Midwest America, and enjoyed it.
What'd mom and dad do?
So father was a professor. My mom stayed home. My father taught. He was an organic chemist by training, got his PhD in organic chemistry in England, and matriculated to the United States, where he became a professor at Youngstown State University. And then a couple years in his training, had the opportunity to shift into forensic science. And it was an opportunity he saw as a pathway to earlier tenure. So he ended up studying forensic science and became, which was really cool for me, the chair of criminal justice. So he was a chair of criminal justice in Youngstown, Ohio. And it was a lot of fun for me because it's a great flex. Your dad's the professor of criminology. And that was before CSI came out and it became cool. But he was a chemist, so he understood crime scene analysis. He would understand polygraph testing before it was like even widely known.
Before Law and Order, even?
Before Law and Order.
Get out.
Yeah, we're old. We're old.
Wow. All right. So that was, were you in awe then of Dad in terms of what he was able to do? Because your parents are first generation immigrants, right?
My parents immigrated from Pakistan in the early 70s. And my brother was born here in 71, like the end of 70, 71. I was born in 72. So, and then we really were born and raised in small town Ohio and just had a great time. My parents were there. They had a lot of friends from the community there. And it was just a great experience.
Was education like a must for you guys?
I wouldn't say it was the only thing. I think there was, without question, a demand to take advantage of opportunity. And where my parents were from and where they grew up was there was a lot of benefits, but it wasn't the meritocracy the United States of America is. Like here as a country, the perception is you work hard, you can get to the next place, the next place, and the next place. And that was the American dream. And my parents came for the American dream. They worked hard. my father got his PhD, and all he wanted to do was get to America, because this is what they dreamt about from all over the world. And he wanted to work hard, and he wanted to participate in the American dream. And so for us, it was the same opportunity. Now you're here. We did the hard work of giving you a chance. Don't squander this chance. Do well in school, do well in everything that you do, but take advantage of the opportunities in the greatest country in the world.
And they must be so proud right now. Like, they've not only lived the American dream through themselves, but they've watched their kids. And how many grandkids do they have?
So they have 7 grandchildren. So I have 3 kids. My older brother has 4. There's just the 2 of us. I would say, Ari, that's a good question. I think they're absolutely proud, but they're like any other parents, are constantly still driven. So they're always pushing you to do more and more in a positive way. You know, get out there, make an impact, make a change, do something great. And then they shifted a lot of that pressure to your children. So they want them to make sure that they don't miss out on sort of the American dream and what opportunities there are.
Amazing. So you have an older brother or younger?
I have an older brother.
Okay.
And he is the classic older brother. While he's only a year and a half older than me, he's very similar to my parents. And I don't want to say he was their favorite, because he wasn't. My parents loved everybody equally. But without question, as the firstborn, there's an expression in another language, translated in English, says it's better to be a dog than a secondborn. And in many ways, in my house, the things my brother did were amazing, and then I was kind of an oh, by the way. And it's like a textbook of what it's like to be a secondborn. You'd find your baby books, and his would be finished, and mine would have like page 1 and 2 written, and nothing else. And it was like that, not just growing up, but it's still like that today. Like, they go to him with their questions. They go to him for everything, regardless of what it is. Like, he's an ophthalmologist, but they ask him.
Doctor.
But he's the doctor for the family. Like, I'm a critical care physician by training. They still ask him questions about everything. No offense to ophthalmology, but perhaps he doesn't have the breadth of experience that you would have in primary care.
The depth.
Yeah, the depth.
Got it. All right. So my brothers and I, we talk about a depth chart, right? So I am the firstborn of an immigrant family as well. And so, and firstborn males, tend to, from the Middle East, tend to have a little bit more of this like patriarchal nonsense. And we talk about the depth chart. So I started really well in the depth chart as the firstborn child. But what my brothers have told me is that, you really got to hold on to it, because you can really lose that if you don't give mom and dad the TLC that they need. So, yeah.
I think you grew up in a lot of ways probably the same way as me. Like, the pressure for education wasn't there to look better, but it was there to make sure that you could take care of your family and take advantage of these opportunities. Is that how you chose medicine?
Oh, my God. Yeah. I mean, medicine. So my story into medicine was a little bit more nuanced. There was for sure the expectation of education. And I mean, the stereotype of it, if you're Jewish, you're going to be a doctor or a lawyer. That's what every parent wants. Okay. That, I think, was inherently somewhat there. But I had minimal change disease, and I was steroid dependent. And so I was really sick as a kid. When I say sick, I was chronically on steroids. And my mom would take me to these doctors. And I remember sitting in the room with the pediatric nephrologist. And he examined me, and he said, all right, can you leave the room so I can talk to your mom about your condition and what we need to do? And I was like, no, I'm going to stay. I was 8. And we did this back and forth. And then he said, my mom, as we were leaving, she grabbed my hand, and she said, we're going to find you a doctor that's going to take care of you. And that was like a formative, seminal moment, right, of advocacy. And I was like, oh, I'm going to be a doctor. So that started I'm going to be a doctor, but who knows what that means, right? To be a doctor, it's a broad range of stuff that you can do, right? What I understand is that I'm a caregiver. Like, I tell people it's very selfish. I feel really good about myself when I can help somebody else. Like, so that means I'm doing something in my day and my life. Does that make sense?
100%. I couldn't agree more. I think there's a beauty of going into healthcare that, and an opportunity is so many people wake up and want to make an impact and want to make a difference, and everybody does in different ways. But there's something very obvious about making an impact in healthcare and taking care of a human being. And it doesn't matter what field in medicine or where you are in the healthcare spectrum. being able to make a difference to help somebody else's life be just a little bit better is probably the greatest thing that you can do in a day.
So I'm going to jump around a little bit, but you've had this, you have this ability somehow to galvanize a group of people, an institution, an organization at large. How many employees are at Rush?
About 12,000.
About 12,000 employees, to genuinely care. Now, look, of course, it's a bell curve, right? But the mean, if you will, is much wider than it was before. And I would say if there were some metrics to measure that, I am sure that we have those numbers. How have you been able to infuse care back into the healthcare system, which can often be a tough place to maintain the ability to do that?
You know, I think this is such an important question. So I often feel disingenuous when you get credit for doing things, especially when something great works out, because there's always so many people that do it and so many giants have great ideas that make such a profound impact. I had the luxury of being in the right place at the right time and an opportunity to take a lot of ideas that my predecessors put together and really build some of those and support those, not even build, but support those ideas. And I think one of the most important parts about leadership is finding great people and letting them be themselves, getting out of the way and letting creative, visionary ideas come. There's so much noise right now in the world that visionary ideas or dreams that people have get killed before someone even takes a chance. So by that, I mean, like when you have a great idea, you say, I'm going to go out and try this or that. You get worried now. Young people get worried. Well, why would I even try? Because there's someone that does this even better. Why would I do this? Like I ran track in high school. I was okay. There were a couple things in my high school I was the best at, a couple things I was second, a couple things that I was third in. I would go to a track meet sometimes, get a first, a second, and a third, come home and feel like a real athlete. Today, kids will look and say, well, what's the point of doing it? I'm not even in the top 200 in the state. Like I'm not even in the top 300. So you miss experiences because you don't want to try, because that noise that comes from outside is so great. People don't try some things. Well, when I got into my foray into medicine and certainly my foray into leadership, I realized that everybody I was working with really wants to make a great difference, wants to make an impact. They're held captive by dogma. They're held captive. We in healthcare are held captive by this paradigm of all of this regulation, all of this documentation, all of these rules. And if you can get rid of those rules and just let a person take care of someone, they can't wait to do it. Doctors, nurses are amazing people. I met a doctor who just came back from a trip overseas where he did like 20 cases in the morning, 20 cases in the afternoon, patients lined up from some country. I think he was a urologist, and he was doing this amazing work, 40 cases. At the end of the day, he loved it. He couldn't believe how amazing it was, and he couldn't wait to go back. Well, he gets back to this country, does 8 cases in the morning, 6 in the afternoon, documents all night, goes home exhausted. All he wants to do is take care of people and make a difference. When I took that learning and that foundation into leadership, I would say that I really wanted to first be honest with everybody around, saying these are the challenges we have. Let's try to solve these together. Bring people together around solving problems in the same way. But it really starts with knowing where you're trying to go. And as a healthcare organization, we had to be clear on what we were trying to do. What are our goals? I think if you're schizophrenic because there's so much to do, you're going to do a lot of little things, kind of good, but not great. If you really get laser focused and this is where we're trying to go, this is what we're going to do, then you can crush it. And so for me, it wasn't me leading an organization. It was the organization having a desire to make an impact in our community. We were going to improve the health of our community. And then when I got the job, I viewed it as taking out as much noise as I could and letting great people do the things they needed to do.
So I hear you saying focus, empower others, and is you said like remove the bureaucracy where appropriate. Now that piece, I'd love to like learn, right? I have found academic medicine to be totally mind-blowing in how much is regulated by perceived risk. We can't do this because of this process or this risk, or how do you handle that?
Yeah, I would say, Ari, in truth, my guess is here you have this amazing state of the art practice where you're offering incredible total care around wellness. And there's a risk to everything that you do too. There's a risk to, you're managing a lot on here. You're going out on a limb. You're giving really important advice that's going to change the direction of what a person does. If it doesn't work out, they don't like it, they come hard after you. They come hard after people. I think that the truth of the matter is, unfortunately, we spend a lot of time and we spend a lot of resources around the regulation that came from a good place. It wasn't like there's some evil czar sitting in the world saying, I'm going to make hospitals incredibly the most inefficient organizations on the planet. But I do think what's ended up happening is inadvertently we've created so many rules and regulations that there's a rigidity to driving change. And there's a rigidity to adopting new ideas. And I'll give you some examples. So, I'm with some people in this room that traveled here from Los Angeles. And my guess is they were able to buy an airplane ticket. They were able to get their Ubers. They were able to figure out where to go, where to eat, where to make a reservation without ever talking to somebody. My guess is they were able to use their phone, get everything done, be incredibly inefficient, get everything they wanted, and figure out exactly what the weather was going to be and how long it was going to take them to get to the office where they had to work. Well, fast forward to going to a doctor's appointment. It's actually today, in a world where we've solved this, where you can travel from here to Singapore without talking to a single person and book your tickets before you leave here, to going and filling out paperwork before you go. When you get to your appointment, refilling out the same paperwork because someone says it's not here or it didn't transfer to this form or that form. You fill it out again, then you get a sticker to prove you're you. You hand out the sticker, you give your birthday 3 times, and by the time you're finally sitting in front of somebody who's barely looking at you because they're obligated to write everything that you say down and get credit for the quote-unquote visit, we've created this system where there's so many rules that the spirituality of the doctor looking at their patient saying what's going on is gone. And if we could adopt that technology that other industries have figured out how to streamline their organizations and take that noise out of the healthcare ecosystem, then we can get back to what people used to love about medicine, was looking at your care provider in the eyes and saying, hey, I'm scared about this. Like, I don't know what's going to happen to my memory.
So at Shift, we are, I don't know if infatuated is the right word, but like we love AI because AI is not done for us. It's done by us, right? So how we use it and we engage with it, et cetera. How are you guys thinking about AI in a meaningful and substantive way? And where is it going to be standalone? Or will it be standalone, and where is it going to be with real life human interaction?
So what a great question, Ari. And I wish I was smart enough to answer that, because the more I read about AI, the more confused I get about what it is and what it means for the future. All the different terminology around it, how it's supposed to somehow magically solve every problem in the world. I heard the other day that one of the most influential leaders on the planet had said in 20 years, no one's going to work anymore. Working is going to be an option like it is gardening. You garden if you want, or you can go to the grocery store and get all the vegetables you want. That's what the future is going to be. I'm sitting here trying to connect the dots for how do I go from here to that world? And what do all people do? And how do we all take care of one another? And I'm confused. So I tell you that to be truthful, to say we know that we have to leverage technology to make our business more efficient. There is no question that healthcare has a lot of problems today in America. But not all problems are someone's fault. Like it's a fragmented healthcare system that get put together over time, and none of us would go back and build the same system. But if you could leverage technology to take the extra work that feels meaningless out of it, and that work still gets done, then you're going to drive real positive change. So I'll give you a couple examples of where I see not necessarily artificial intelligence, but technology linking to artificial intelligence making an impact. When one of your listeners sees a doctor, they want their doctor to look at them in the eyes and talk to them. What they don't want is their doctor to be tilted over 30 degrees on a computer, writing everything they say down, turning, talking. They don't feel heard. They definitely don't feel like someone is empathetic and is connected with them. So what's come out is ambient listening. And ambient listening is this technology that I know you know about, but maybe some of your listeners haven't, where when the doctor's talking to the patient, world, the note is being generated by little microphones in the room. And those microphones are taking the conversation and converting it into an actual note. And that converting an actual note should save time for that doctor. So later they can read the note, go through it and say, yeah, this is right, this is right, this is right, fine tune it, boom, pop it off and send it. And then that note sits in the medical record. All the other doctors are taking that patient, see it right away. Without question, providers love that tool. Now, there's a bunch of them out there, and they're all competing against each other, which I guess is the American way. In the end, all the doctor wants is make my tool work, make it count for coding, make it count for documentation, but make me not have to write so many different things. So make me not have to prove that I did so much different work.
Let me play up in my craft. Let me be a great physician and use my brain and use my social and
For what I'm
emotional
supposed
skills
to.
for what I'm supposed to do. Don't make me document 60% of my workday.
So Ari, here's a great question for you. You left and you trained at some of the most elite academic medical institutions on the planet. You left and started your own way of caring for human beings. You started your own plan. My guess is part of the reason you did that was so you could look at people in the eye, hear what their problems are, give them the solutions that you truly felt like they needed and they wanted to talk about. That's hurtful for everybody in academic medicine because they have the same goals. They're just in this trap where there's so many rules around it right now that without breaking that down, we can't get to what you've built. You had to effectively build a new model of care. Like what you're doing is not a conventional care. It's a new model of care which puts a patient at the center of everything that you do. That's what every doctor wants to do for every patient that walks in. I've never met a doctor in my entire life that doesn't want the patient at the center. They are all advocates. But I have met many doctors that are incredibly frustrated by giving a flu shot in their office and having to do 19 clicks on a computer screen to give the shot, right? It almost makes you not want to give the damn shot.
So what's the question?
I forgot. Did I say I was going to ask a question? Oh, what made you leave? Like, why take that on?
It's a really interesting so it's a great question. So I think the answer is probably a couple-fold. One, this idea was actually born when I was in college. So there's a picture right over there, right behind Cody, that has 19 bullets of what was called proactive health that I wrote my junior or senior year in college when I had a Hotmail account, way back when Hotmail existed. And it was about this premise of how the obesity crisis was going to keep going on and diabetes was going to continue to grow. Like, we weren't able to do what some of the hard stuff was. We weren't able to do the work, the heavy lifting of, like, how do you help people change? So that was always an idea that, like, was very present for me. In medical school, I worked on it. I went back and got my MBA in medical school, and that was an experience and a moment for me that was transformative. It must be what a drug addict feels like, because I got there and suddenly I was like, oh my God, this is the language that I need to be using to articulate what I'm thinking. And suddenly I had, and it's a different skill set, right? I mean, you are probably, I'm sure, experiencing some of this and have experienced, like, it's a different language to talk business acumen and understand how things get measured, et cetera. And so for me, what that did was that ignited a fire for me about this idea that I wasn't able to have before, because I couldn't necessarily articulate it and find how to do it in the actual system. And so in my residency, I found myself quickly thinking, am I going to go do a cardiology fellowship? Because that's the next step, right? Am I going to take a job in an academic healthcare system, or am I going to do something else, right? And what is this something else, right? Which was this idea. I ultimately took a job at University of Chicago and helped build some of their programs, and I was able to do some what we call intrapreneurship with them. So I built that offsite location. But why I went into this was because there was no meaningful reimbursement pathway that was going to allow me to grow and demonstrate a feasible business model, right? Every institution, has all these add-on costs for overhead, et cetera. And so how you were going to do, I couldn't find a way to do that. And so I thought, well, I could try and be a researcher and get a K1, et cetera. And then I was going to be dependent, right, on the dollars from what I was going to get, of which, depending on each institution, I don't know what Rush takes, but it can be anywhere from 42 to 57 cents on a dollar. So whatever I was going to get, I needed more than, right, to give somewhere else. And I thought, well, why can't we actually see if the consumer wants this? So as a practicing physician, I was like, people want this. Once they experience it, they want to do it. So I thought to myself, like, I might as well try, right? Now, that's a very simple part of the story. I wasn't able to get there until my mid-30s. So my son was born. So my second child was born, and I was having a little bit of a conflict of conscience. Like, I'd had another startup company that I did while I was practicing, and I was doing stuff with the Blackhawks. I was doing all these things, and I really felt like I was underperforming. I just wasn't. The language at the time was it was time for me to put on my big boy pants and be an adult and really go after this. And so I remember I was on a big trip trying to sell for the business that I had, and I was actually in California. And I had a flooding of ideas, and this was it. And I came home to my wife, and I was like, I have to try it, right? Because I didn't want to. The fear of not doing it was, too much. I couldn't stand that, so I had to figure it out.
Yeah, no, I get it. And I think that's amazing, Ari. But I think that, to me, if I simplified it, you had to block out the noise of what everyone said conventional medicine has to be, and then you went and built something different. I think healthcare in America has to figure out what we want to be. I think that where we're a little lost as a nation is, it can't be, see, healthcare in America is driven by like one-sided capitalism. So every healthcare institution in this country is obligated to take care of any patient that shows up at his front door. So any hospital patient has to come. It doesn't matter where they're from, if they're insured, not insured, legal, undocumented, whatever it is, you're just taking care of that human being. We treat all human beings in healthcare when they come in front of us. So I think that's the expectation, right? That's the law. But at the same time, there's no other industry that works like that. There's no other industry that says, I have a plumbing problem, come fix it, no matter what. There's no other industry that has that. I agree with that. I think we do have to take care of every single human being in this world. And I think every single human being in this world should get the same level of health care. And that's an obligation we have as a global society. That said, the cost of the beds that we use, the IV tubing that we use, the beds in your office go up every year. But the payment models go down relative to that increase every year.
Yeah, I mean, it's
so it's hard to explain how to make it work. Like, it's hard to explain to say, all right, well, that math doesn't add up. It's capitalistic for everybody that sells you something, but the payer is decreasing how much you're getting every year.
Yeah, and it's not capitalistic when you have a third-party payer, right?
Yeah. Here's what I would tell you, especially since we're being recorded. I don't know, but here's what I do think is true. If you are a sick human being, you absolutely have the right to get the highest level of care. We are in the greatest country in the world. We offer the most advanced medical care in the world. Every single human being in this country should have access to that medical care. How we do it, how that gets arranged, we have to figure out as a country. So that has to be taken out of the grand scope of goods and services.
100%.
If you have a sore throat, you should get and it's known as strep, you should get antibiotics.
100%. And what I'm going to put, because you're not going to put that on, what I will say is I think that there is and should be a reckoning around insurance. So if we look at, now let's step back. I understand why health insurance exists, why it's in the marketplace, why it adds value, right? If we look at profit margins of quality institutions, however we want to define that quality, the profit margins over the last 20 or 30 years will watch a steady decline, right? If we look at profit margins of insurance companies, right, we'll see a steady increase, right? Maybe some flatlining, but you'll see a consolidation of the ones that couldn't figure out how to do it, and otherwise you'll see a large growth there. There's no normalization of the profit between the two of them, right? And I mean, I think there should be some alignment there.
I think that the United States government needs to come in as an unbiased third party and say, as a country, what do we want healthcare to look like? And if we had an empty slate, what would we build? What are the players? Where would insurance come into play? Where would providers come into play? Where would private equity and venture capital come into play? Where would pharma come into play? The challenge that I believe we have right now is we're trying to solve. So 20 cents out of every dollar in this country goes to healthcare. 4 cents, 5 cents of that goes to the providers. 15 cents goes to people that very often are not in the equation for how to fix healthcare. So a huge part of the resources in this country, we all have to come to the table and bring solutions to the healthcare challenges that are impacting this country.
What do you think about when somebody says healthcare is actually two different systems, healthcare and sick care?
Yeah, I've heard that, Ari, and I, obviously I think that. So the first thing I would say is there's a lot of clever ways to restate the problem of the healthcare system in America. But I would even simplify it and say that that's exactly right. Like what you'd want to do is, as a global community, is people eat healthy. People exercise their brain. They read. If you do this, you will live a healthier, longer life. And likely a more happy life. That's a healthcare system. That is not a reimbursed healthcare system. But if your heart stops, that is a reimbursed healthcare system. And that is what you're referring to as a sick healthcare system. So for the people listening, we incentivize treatment when someone's really, really ill. And the sicker you are, the more we incentivize it. But it's not a linear curve. And this is really important. Like if you spend $1 in healthcare, you don't get $1 benefit out of it. But if you spend $1 in healthcare very early, you get a massive impact improvement. If you spend $1 late, you get a very little impact. There's been some studies that show 60% of the total spend in your entire life on healthcare happens in the last 6 months. Like, I don't think any of us could sit there and say, oh, that makes a lot of sense. Let's just ignore healthcare all until a person's about to die in an ICU and then throw tons of money into it when it's not going to change the outcome. Whereas in reality, we can invest a much smaller amount of money up front and improve longitudinal health dramatically. That's a well-centered healthcare infrastructure.
Amen, man. What needs to happen?
So here's my belief, and I believe this 100%. There's a lot of frustration. There's a lot of political frustration in the country right now and in the world right now. There's a lot of general frustration and rage. There's an increasing wealth divide. There's a lot driving community frustrations in just about every community, not just in the United States, but in the world. I would say when your question is what needs to happen, let's take healthcare out of that conversation. Let's take healthcare out of a political conversation. Let's take healthcare out of a geopolitical conversation and just say, what, if we were starting over today, would we want from our healthcare system? And this is a problem we're trying to solve. Optimize the amount of care that everybody deserves to get and figure out how to deliver it. And not just make sure people who are affluent get good care, but everybody get good care. If we have that conversation, if we dial it back and say that's a conversation we're going to have, we're going to start to change things.
Yeah. The other thing that I think is really interesting about this is what I find difficult about healthcare is that while there are a lot of problems, everybody is looking to rapidly scale a solution. And I mean, we've seen a lot of different primary care models, that have come and gone because of speed, in my opinion, speed of scale, whether it's, One Medical, ChenMed, there's a lot of different, we've seen some progress, but do you think healthcare can change at a rapid enough rate, or is it going to be?
So here's my honest belief on that, Ari, and I'm sure your audience is going to have all kinds of different opinions around this, but the United States of America has been the most innovative nation in the world since its inception. It has solved problems no one could solve. It ended wars using science. The Manhattan Project showed what can happen when you bring the greatest scientists together under an umbrella of saying, this is a problem we're trying to solve. And I think if we were to take a step back, and your question is, where do we go from here? I'm optimistic because it is in the essentiality of having to drive change, we will as a country drive change. Like, I truly believe that. During the COVID pandemic, we took what takes years and years of research to come out with a vaccine, and came out using Operation Warp Speed of a vaccine that allowed the world to reopen. And instead of celebrate that, it's mired in controversy, which I don't really understand. Like, I believe that people involved with creating the COVID vaccine should win Nobel Prizes. It allowed the world to open again. Rather than celebrate it, we're like talking about how it's not great. Right. I don't understand. Like, I'm at a loss for words. I'm at a loss for words of where science took a back seat. Like, what was scientific is losing to TikTok. And no offense to TikTok, but I would think science would win. So we've never lived in a world where we're challenging scientists. So here's the exciting part, I believe, of the future. I think that it takes the stress in the ecosystem of healthcare that we have right now to create the change that we're going to need, because we can no longer take Band-Aids on a broken healthcare system. At some point, we're going to have to rebuild our healthcare system. And I think that's what's going to happen in the future.
That's awesome. I can't wait to be a part of that rebuilding of the system. Talk to me about the moment when medicine became personal for you, when you actually realized that you were going to become a doctor. So there's a twofold question. What was that moment like? And then, was it a calling, like, once you got into it, or were you like, oh, I'm burning, I can't do this?
So I wish I had a moment. I get asked questions like this sometimes, and I wish I had a moment where I can say there was this clarity of purpose and I knew this is what I was going to do. I would say differently. I had a desire as I was growing up to wanting to do something good. I don't think that's not to say I'm a good person, bad person, whatever kind of human being I am. I had a desire to want to make an impact and do something meaningful and do something good. I got to college, I didn't know what that was, and I didn't know how to do it. I think for me, college was hard. Like, I was lost. Growing up, I was lost. I didn't necessarily know exactly what I wanted to do at every stage of my life. Somewhere along that journey through school, I started to enjoy a couple classes, and they were actually in religion. I ended up getting a bachelor's degree in religion. And in studying religion, I love the spirituality of all faiths. I love the centrality of love being at the center of what everybody does or what everybody believes in. And to me, it didn't so much matter as the formalities between the differences between all of these different faiths. What mattered to me was how they were all beautiful. And that if you practiced any one of them, you were going to be nice to your neighbor. And there wasn't a big, ethereal difference between all of these. And so in the end, what happened to me was I loved that. I ended up getting a degree in religion because I always wanted to make a difference. I did enjoy taking some of my science classes. I ended up saying, all right, I want to go to med school. I want to study medicine. To me, I didn't have that love of science and studying a cell and a microscope. I wanted to go talk to human beings and see if I could help. I wanted to see if I could make a difference. I wanted to see if I could improve something for someone. I think the most selfish thing you can do, Ari, in so many ways, is helping somebody else. I think that it's truly a selfish thing because I don't know if you're doing it for them, but I know you feel good when you do it. The first code every med student runs, or when you're a resident, you run a code and someone's heart comes back. Regardless of what happens, when you run that code and their pulse comes back and that code is over, you float home. You don't drive home. You don't walk home. You float home. You can't believe you are part of something so amazing. There's also a spirituality in medicine that I've always been drawn to. There's this amazing connection you get to make with human beings when they're going through something. And if you can make that journey for them it all better, then that's got to be a good thing. And I think for me, maybe it came out of a need to wanting to do something for other people. But again, I wish I could say there was some altruism there, but I don't know. I don't know what drove that desire to make a difference. I know that today you wake up and you say, I want to do something good in healthcare. I want the healthcare systems to improve the health of our community. I want to make a difference. And it started when I was an intern, and it lasted until I was CEO.
What was it like transitioning from being a pulmonary critical care doctor, right? It's a pretty intense, right? 2 weeks on or a week on, week off. Like, I don't know what, your structure was, but it's a pretty intense window. Were you getting burned out? Did you need to, did you have to get into sort of the bureaucratic side of medicine or the business of medicine?
No,
Or?
my journey into the business, it wasn't. So first of all, I'm not a business guy, and I wasn't then. I'm not now, and I have a lot to say about that in a second. But I will say this: I was a practicing physician, and I loved my. To me, it was the greatest job that I've ever had. It was a gift, an opportunity to take care of people, an opportunity to make someone else feel better. And it was just great in every way, shape, or form. I wasn't tired going to work, and I looked forward to being on service. There was no burnout at the time. There was nothing but excitement. What I didn't like was when I would get a phone call from someone sitting in an office telling me we had too many infections. Or I didn't like when someone was in an office calling and telling me, I don't think you guys are washing your hands. And I'm thinking to myself, you must have really good eyes to see that from your office 3 blocks away. So my interest in going into healthcare was because I didn't like the people outside of healthcare saying what was good and bad. I started my interest in administration and trying to understand outcomes. I didn't want people saying you're good or you're bad, because everybody I ever met in healthcare was great. Not good, but great. And to me, it came from a very selfish perspective of proving that the metrics that are measuring better be accurate and better be right. So that's how I ended up becoming the chief medical officer. My journey into it was trying to prove that the care being given in different areas of the hospital was actually good care, and perhaps maybe some of these metrics were wrong, and that we need to do a better job monitoring what good care and bad care is. When we started to understand what good quality was and bad quality was, we got teams together and we really worked on improving our quality. And Rush as an institution won a lot of quality awards because of the doctors that worked at Rush, not because of me, because the doctors and the nurses that worked at Rush did an amazing job taking care of everybody they were taking care of. Their quality scores in many years was #1 in America in predicted mortality in the Vizient database. And mortality is life and death. Being #1 in that metric is a pretty big deal. And so that meant a lot to us. And that's what mattered. And that's how I got into it. When you say, was it easy to get into it? I can't imagine anything harder than getting into it. Because when you go through 4 years undergrad and 4 years of medical school, you think in a certain way, and 6 years of residency and fellowship, 3 years internal medicine, 3 years of pulmonary critical care. When you graduate, things are pretty simple. You take care of a person. If someone's not treating it, you escalate it and you go from there. The rules of administration, not just in medicine, but administration and in the business world, are very different than the worlds in healthcare. Healthcare is everything has to be solved that second. You have to get to an answer. I worked in an ICU. If you felt like you needed to get closure at that moment.
You have to, because they die.
You have to. You just and you have to, because even if they don't die, you can't go another night without getting finality in what you're doing and why. When I became an administrator, I quickly learned phrases like chain of command. Like, oh, well, you better talk to this person first. Let's get everybody involved. You're not going to drive change by pushing it through. You can't make everything is not a 10. For me as a critical care doctor, everything was a 10. It was out of a 1 to 10 scale, everything was an emergency. And I was probably not good in burning people out around me as I was learning my administrative roles. After a while, you realize what's a 10 and what's a 2. They all have to get fixed, but you have to bring people along to get change management. You can't force it through. In an ICU, you force it through because there's no time to wait. In administration, you have to be able to drive meaningful, sustainable change, and that doesn't happen if you force it in. You have to kind of win the hearts and minds of everybody in an organization to make change.
How are you building that muscle then now?
Yeah, I think that's something that doctors have to do. If doctors don't drive the changes in healthcare, then the people that drive it aren't going to be doctors. And I don't think that helps physicians. I think physicians have an understanding of what happens at the front line. Nurses have an understanding of what happens at the front line. PAs, APPs, they have an understanding of what happens at the front line, and they have to drive change. And I think that without driving change, you have people that are well-meaning, but don't have the breadth of the depth of understanding of everything else.
Because they haven't experienced the friction at the ground level. And there's a requirement there to actually experience the clinical aspects of it, as well as, I guess, what I'd call the social emotional ones, right? The loss of a patient, the mourning of a family member, the implications of when you can help somebody or you can't.
That's right.
Talk to me about being a dad and a public figure.
Well, I'll talk to you. One of the bigger challenges of leaving sort of practicing and then becoming kind of a leader in an organization is It is very public, and there's not like a class that tells you the day you take your job as a chief medical officer, the day you take your job as a chief executive officer, that all of a sudden the things that you say carry a different weight, or the things that you do carry a different weight. So not as much about being a dad, but being a leader, I would say. One is I'm going to go drive change in an organization and try to improve different outcomes and improve different metrics and offer better service to the people we serve. Another was I'm an emotional person, and I've always been an emotional person. That is not. I'm going to tell you, that is not a great. That is not a trait that makes it easy to be a leader, because there's always going to be people, regardless of what you do, that can't stand what you've done. And they're going to be vocal about it. So you have to have thick skin. And so I don't have the same level of thick skin as many other people. So it wears on you. So the part of being a leader that's amazing is being able to have an impact and drive meaningful change for large numbers of people. Having programs like the COVID response at Rush, I think served as a national model for how to treat people. It won all kinds of national acclaim. Being a part of the team that drove that was a gift. It was an opportunity to make an impact. Facing the criticism of everything that you do, you have to be strong. And that's something that you don't realize. And I don't know how natural that was for other leaders to walk into it, but there's a difference in being a physician for being a CEO in terms of the blowback that you get for every decision you make. And so for me, that was challenging, and it's still challenging today.
So where and who do you go to when you need a moment? Because, you are emotional. Great. You're like every other human being that exists. Sure, you get mad, you get angry, you get sad, but, you're on camera a lot, and you understand the implications and the pressures of that. So what do you do?
Oh, I think one, I feel incredibly fortunate beyond belief. Gift, like an opportunity and a gift, and sort of a special thanks to God for having an opportunity to be in a position where you can drive change, to be in a position where you can make an impact. That's amazing. So your question is, where do you go when you have everybody, no matter what your job is, going to have a bad day. I have a board that I go to, friends, family, for sure my wife, places you go when you have a bad day. But I would say this, the single most important thing, and this isn't kind of me proselytizing on what good leaders or bad leaders, but for me, what I've realized is that whatever you do, there's going to be criticism, and there's going to be people that are behind you. There's going to be people on the pro and people on against you. You have to believe that what you're doing is meaningful, and you have to have a true north. And if you stay to that true north, you'll be okay, because people are going to hate no matter what you do, or people are going to love no matter what you do. But you have to believe that what you're doing is the right thing. So we're going to take care of the sickest people we could find with COVID, no matter what. We're going to transfer them here. We're going to make that difference. And that's it. If it costs you some money, it's okay. Our boat is going in this direction, and everybody on it's rowing in the same direction. That provides, so if you're not sure of what you're trying to do, then you'll collapse. So you have to really believe that the vision of what you're trying to accomplish is the right vision. And that's in healthcare or in any leadership role. And if you at least believe that, then you could handle the negativity around it.
Got it. So I hear you saying purpose, right? You have to have purpose and passion for your purpose. You've got to be aligned there. You have to have people, right, who are around you to help you, support you, catch you, let you be you when you need to. And then you have to be persistent.
Yeah, I think, but getting the people thing, I think the greatest leaders are the people that get people smarter than them around them and let them do what they need to do. You have to find people and put them in the position to drive the change they need.
How old were your kids when you became CMO?
CMO, I think they were Chief Medical Officer. They were young. CEO was 6 years ago. So, 14, 12, and even younger than that. So they were all in school. So I think part of the challenge for me was it's a 24-hour job. There's a lot that you're doing at nights and weekends and things like that, and you also want to be at all their events. And so that was tough to balance a little bit.
What was the deal you made with your wife? How did you figure that out? Like, did you talk to your kids about, because you're like being a father is super important to you, right? And how do you handle missing stuff?
Yeah, so I look, it's like every single family that we know growing up make sacrifices one way or another. Everybody, and what I would say is the things at work are it's going to sound crazy. It's just being transparent, being able to communicate. You got this one, I got this one. We're equal partners in a relationship. My wife and I are equal partners. The kids understand what's happening. Anything important you get to, anything not important you don't necessarily get to. But you have to, and it's interesting, each kid is different. Each child has a different set of needs. Each kid wants you to do different things. One kid may want you at events, another kid doesn't want you at events. I think for us, it was really just understanding one another and then sharing the responsibility. And I think that the best relationships, the best families have families with just a lot of shared responsibility. They're all doing stuff together. I have never met a person of faith that wasn't incredibly kind. My office has all kinds of quotes from different spiritual leaders from all kinds of different faiths, and I studied comparative religion. To me, the value of faith is traces back to the concept of love and everybody taking care of each other. You can't eat if your neighbor is starving is a pretty universal phrase. You save one person, you save all of humanity. Old Testament, New Testament, Quran, it's in all books. I think that the reality is that doing something good can never be wrong. And as a global community, we have to stop focusing on the differences between everybody's religions and look at the similarities between everyone.
Well, I think that that's something that is a tie that really binds you. You are a great convener of people. And so you, as you said, right, you let people play up into their best and you give them the space, right, and the permission and albeit like, I guess, a little bit of the safety net, right, to like go do. I mean, we haven't got into, I mean, you've alluded to it and talked about it, but U.S. News and World Report. I mean, I don't know if you want that for this podcast.
Sure.
Totally, like...
Yeah, let's cover that.
Yeah, I'd love for you to tell the story of how you unpacked quality rankings.
Yeah, so this is a fascinating story. It's not just the U.S. News and World Report, it's how quality is measured. So this may bore some of you, but this is like the most exciting thing on the planet. And so if it bores you, then you're wrong. But what I would say is there's this great desire on the part of everybody outside to rank. Everything gets ranked now. Best high schools in America are ranked. Best gyms for gymnastics are ranked. Best everything is being ranked. Best podcasts are being ranked. Best podcast recorders are going to get ranked. There's going to be an outcome measure for everything that's being ranked. Well, there's a list called Best Hospitals that the U.S. News and World Report comes out. If you Google what's the best hospital, all kinds of different rankings come up. And what was fascinating to me as a person that likes science and evidence is there wasn't similarities between the programs that were number one on the different lists. So if you're the best long jumper in the world, and there were 6 different measures of looking at the best long jump, the same person would be number one in each of them. Who's the fastest sprinter? Usain Bolt, Usain Bolt, Usain Bolt. What's the best orthopedic surgical program? They're all different, right? But what's not explained is why are they different? So I'm looking at it and I was wondering, why as a society have we not asked, had there 6 different rankings that are entirely different across the board? They're entirely different. So then we decided, let's take apart one of them. So the U.S. News and World Report is one where everybody quotes all the time. We're on the U.S. News and World Report. That's great. Nothing against the U.S. News and World Report. I wanted to understand it. So for us, trying to understand it wasn't that easy because it's very complicated. They give you a list of how they make measurements, but they don't give you the details behind each thing. They say we're measuring quality, and that's a 1 through 5. We're measuring survival, that's a 1 through 10.
But didn't it come to your attention because Rush changed from year to year without any substantive? Yeah.
So we in one metric, we were ranked in the top of the country in quality, and in the U.S. News and World Report, we were ranked in the lowest in the country in quality. Like in a 1 out of 5, we got a 1. In another metric, we were like in the top 1 percentile of 4,000 hospitals. So I was sitting here trying to figure out how that possibly makes sense. So it turns out they're measured differently. So this is an actual story. We said, what measures, so if you go to a hospital and you die, that should not be controversial. You go to a hospital, you die, boom, that's a number. It turns out that that every patient we saw, we put a code for and their outcome, and that data gets recorded in something called the MedPAR data set. That MedPAR data set is owned by the U.S. government. Turns out the U.S. government packages that and sells it. That gets sold and that gets interpreted, and how it gets interpreted, people make conclusions based on that interpretation. We were trying to understand why our mortality score changed, and we couldn't figure it out based on our data because our data didn't look that different. So we called the U.S. News and we said, can we get our data? And they said, well, we subcontracted with this group. We called that group. They said, we subcontracted with that group. So by the time we found our data, we had to buy our data back to compare it to what we had, and it wasn't the same. So it wasn't that someone made a mistake. It's like the telephone game. If you pass data, you're going to make a different conclusion. So we called the U.S. News and said, hey, look, we don't think this is our data. And they said, no, you can do what you want, but we're pretty confident about our approach. We published an article in the National Journal for Patient Safety and Quality where we showed that our data in this MedPAR data set, and we thought like 5 people would like this article. We showed where our quality in the MedPAR data set was different than what was being measured. And we proved it, and we felt like we proved it. And it was a couple days later, the U.S. News and World Report dropped that metric from their ranking. So they also wrote an editorial. In fairness to them, their editor, Ben Harder, is a fantastic human who is married to a physician who wants to do this right. And, called us after the article, wrote a blog that said healthcare quality is a journey. But here's the important part of that story to us. There are hospital leaders and C-suites getting crucified based on how their hospital is getting ranked. So if that's going to happen, we better be damn sure the ranking's correct. If the ranking's not right, and we're like tearing down leaders, that's not okay. That was our point. Our point is ranking. We're not saying ranking is easy. We're saying it's so complicated, maybe you shouldn't do this ranking. Just have categories, good, bad, good, average, bad. But to differentiate between 1 through 50 out of 4,000, when all of them are the same, they've all trained in the same places, I still, sitting here today, don't think that's possible. I don't think there's a difference between 1 and 19. I think that everybody I've met, they've trained in the same place, they've passed the same boards, they're providing care. If the hospital has more resources, perhaps it does a little better, but I don't think you could differentiate the way they're being differentiated. I don't think that's fair. I think it hurts doctors, it hurts nurses, it hurts hospitals all over the country.
So from that story and from that change, what is now, other than dropping the ranking, because I think you sort of cut that story short a little bit.
Yeah, well, once we started to understand what was being measured, right, we started to know how to build quality improvement programs, and Rush ended up an honor roll hospital in the United States of America. We're very proud of being recognized as one of the top 20 hospitals in America. We also are transparent and we understand what's being measured. We share this story publicly, just like I am with you. We published it.
Yep.
So our journey was published. What we believed was an error in interpreting data. We published it. That was subsequently changed, and that improved Rush's performance. That said, not everybody has the same quality analytics team Rush has. And so if they did, I don't know, would everybody's data be different? Would the rankings be different? I know that the doctors I get to have the privilege of working with are like amongst the best in the country. I also have gotten care in other institutions as well, personally. And my family lives in different cities and got care. I haven't met bad people in any of those places. So I think it becomes incredibly complex to say this one's 1 and this one's 3.
Are there topics you want to make sure we cover that we haven't? Do you want to talk about CMS stuff? Do you want to talk about West Side?
Yeah, so I would say this. I think there's one other subject I think we should talk about, which is I think that the greatest challenge in healthcare today is not that we don't have. I think there's 2 things I want to cover. One thing is inequity in healthcare. We have phenomenal tools to improve the health of people, but what we know today is that not everybody gets access to those tools. If you are a black woman in America, you have as much as a 3 times higher chance of dying from breast cancer as a Caucasian woman today in 2025. That, to me, is an embarrassment to the greatest country in the world, and that shouldn't exist. If you had COVID in America, you had a 3 times higher mortality if you were black and brown in some of the biggest cities in this country than if you were white. I don't think that's something any of us can be proud of. That is not a political statement. That is a scientific epidemiological statement. You would have to live under a rock if you don't believe that data, because it comes out, and it's been coming out for decades. Different outcomes based on the color of your skin. That said, we as a nation need to definitively say that is not okay. And to do that, we know that we have to improve the wealth of the community if we're going to improve the health of the community. So we know that if we use our healthcare institutions as anchors to build up the healthcare, to build up the community, actually revenue in a community, we're going to build and improve the health of the community. So what Rush does is co-founding the Anchor Network, believes vehemently that if you invest locally, everybody you hire is from your neighborhood, and you build wealth in the community, you change the job flow of your community, people are going to live longer from hypertension and diabetes. So while it's sexy to study endothelial cell dysfunction in a mouse and come up with the next great cure, it turns out if you get someone a job in a 401k plan, they're going to live longer. And so that's a huge part of the work that Rush does. The second thing I want to talk about is a fascinating company that I think the founders and the company, to me, are really a breath of fresh air. It's a company called Nuna. And it's a company that came out of Silicon Valley. And I don't really understand Silicon Valley. I don't understand. I see these people, they wear these fleeces, they don't have sleeves. They talk about like getting a 10x return on things. I don't really get it. But this company shows up and says, we have this idea. We're going to give everybody an app, and we're going to ask you on that app in the morning, did you take your medicine? And if you say yes, we're going to give you points. And at the end of the month, you could trade those points in for Uber rides or for groceries or for money, an Amazon gift card, some type of a gift. And I'm sitting here going, well, what's the catch? There is no catch. We're going to pay for these rewards, and we're going to see if we could change the health of a community. So we said, and they were looking for a partner to work with. So we said, dude, if we don't have to pay for the awards, we're all in. Like a Rush, because we don't have money. We're not deep, right? So we'll do this program. So we partnered with this company called Nuna, and the first 100 people with uncontrolled blood pressure on the west side of Chicago that we had download the app, 19 of them went from uncontrolled to controlled blood pressure. There is nothing in medicine that gives you a 20% improvement overnight. But there's something amazing happened. It turns out if you listen to your doctor and you take your medicines as directed, you're going to get better care. That cost of rewards of what, $20 a month is far less than the cost of an admission for a hypertensive emergency. It's far less than an admission 10 years later for a stroke. The cost of the rewards, behavioral modification, games, interacting with patients, getting them to listen. This is our future. Getting people to optimize their care, leveraging technology to get people to optimize their care to drive outcomes. I think the most exciting two things that we've done in healthcare at Rush was to drive a mission around investing in our community to improve the wealth of our community, and then tracing how that improves their health, and then to partner with innovative tech companies to get to people and get them to listen to their doctors. And if we can do that, we'll, as a nation, get better care at a far cheaper price.
Amazing. So you have an innovation arm where you guys will make some strategic investments in tech or other companies that will help?
Yeah, so we don't have the innovation financial money that other institutions have right now to play in this space. But what we have is a proving ground for the technology companies. If they want to use Rush, we would love to partner with them to see if we can
because you have a
drive
pool
innovation.
of people,
We have
as
patients
long as you're
together.
doing well, and you can.
Yeah, and as long as there's a shared mission and synergy in what we're trying
100%.
to do.
So as a guy who has built a model that is it's a cash-based model, right? It's for haves, generally not have-nots because of the cost that it is. How should I'm always thinking about how do we get this to more people, right? The mission and the idea, like it's a wonderful model and I love it and my heart is in it. I want to be able to bring this to more people. How should I think about that?
Well, I think it's critical for all of us to use our voice and tell the truth. I think that, and what I mean by truth is the healthcare truth is that we can do a lot better than we're doing right now. And so, Ari, where you're excelling in your practice is your patients, my guess, have a much higher compliance than the average patient in America. That when you tell them, take a statin, they're going to take the statin because you spend the time, you have the time, you get to go through this whole rigmarole about how this is going to increase benefit to you. I think that one of the greatest challenges we have going across the country is non-compliance with healthcare. I think the message you can get out is we have to collectively fix that. We have a lot of tools that we're not taking advantage of.
And we can totally fix it. I mean, what we know, like bar none, is that when you connect with a human being emotionally, when you understand, like understanding what's going on in the content of the body, those are technical problems. Okay, you have high blood pressure, you've got elevated, you've got high cholesterol, you've got these issues, right? You're not active. Okay, great, you can tackle those issues. But if you don't understand the human being, the context of their lives, the motivations, their early childhood trauma, any of those things, investing that time up front for us pays huge dividends because I know how to show up and walk alongside you.
Well, Ari, you know how to speak the language of the patients that you're speaking with. If you can't connect.
But that's not a different language across.
Oh, for sure it's not. I couldn't agree more.
That patient language doesn't change whether you're affluent or not.
Oh, for sure. It's about empathy. It's about understanding their language. It's about, well, it may change with cultural understanding.
Correct.
Depending on who you're talking to, you have to understand their ethos. And then if you understand that, you can drive behavioral change. I think as a healthcare field, we need to spend a little more time figuring out, it goes to what you said earlier. How do we make a healthcare system that focuses on wellness and not sickness, right? That means you get to a person and understand where they're coming from.
Yeah.
One of the greatest, so we don't spend a lot of time talking about this, and I know everybody's tired, so we could wrap this up soon, but I would say this. Well, the greatest epidemic we have right now in this country is in the mental health space. We have people suffering who are young, who can't get into the healthcare we need. We have some school districts saying as many as 25% of their school districts experimented with cutting. Like literally cutting. We have 20% of people cutting. If you're cutting today, it may take you a month and a half, 2 months to get an appointment to see somebody. That's criminal. That is not, we can do better than that. So I think that what we have to do is understand, and what's happening is we're not understanding the challenges of what people are going through today to drive this kind of behavior. And we're not building the healthcare infrastructure today to answer those challenges. But we could cath a person with heart disease today just about in every city in America. Mm-hmm. But we can't get you if you're cutting your arm. And there's a different level of urgency, but in many ways it's the same.
Where do you get the dollars?
Yeah, that's the thing. That's the question, Ari. The question is, as a country, I don't think we need more dollars. We have to change how we spend the dollars that are in healthcare.
Absolutely. So reallocation of them. Okay. So in 20 years from now, what's the story you hope people say about the healthcare that you helped lead?
So I will say in 20 years from now, I don't care if anyone has any idea who I am or what we've done or anything like that. 20 years from now, I want to believe that in America, we as a country believe all people deserve to be healthy. And 20 years from now, the model of care should support that. And by that, what I mean to say is we have to have access to health care in this country. And that access should be universal to anybody who needs it. That's the goal. If that's the goal, then we need to redesign the healthcare system because we have those resources. There's just a misalignment of incentives and how we're spending and what we're doing.
Awesome.
Thanks so much for your time, Ari, and thank you guys for doing this.
Thank you, man. Appreciate you.